Dear committee, dear audience, welcome to this progress report. In the following, I would like to share with you my topic, which is about the management of cardiac arrhythmias and conduction disorders. So, did you know that 1 in 3 right ventricular pacing patients can develop heart failure during pacemaker? Therefore, effective pacing modalities are needed. In our meta-analysis, we found that conduction system pacing reduces heart failure hospitalization by 60%, all-cause mortality by 40%, and improves left ventricular ejection fraction. Therefore, clinicians should prioritize conduction system pacing in appropriate patients. My name is Bernadett Miriam Dobai, and I am a cardiology resident doctor, PhD student, currently taking part in the bilateral program between the University of Turku and Semmelweis University. My vision is a world with less heart failure, and my mission is to reduce heart failure incidence through adequate pacing modalities. Together with my supervisors and the research team from CTM, we are working on 2 specific goals. We would like to find the best pacing option for patients suffering from bradycardia. And second of all, we would like to investigate the incidence and pattern of atrial fibrillation after flutter ablation. So let's focus on the first project, which is comparing the safety and effectiveness of pacing modalities in patients with bradycardia. Why is this topic important? Because more than 500,000 pacemaker implantations take place in Europe, and this is a continuously increasing number. Patients with AV block and bradycardia require permanent pacing. Although right ventricular pacing has been the standard approach, this can lead to ventricular dyssynchrony and potentially cause or worsening heart failure. Therefore, over the time, alternative pacing modalities have emerged, such as biventricular pacing and conduction system pacing. However, the comparative effectiveness of these pacing modalities in patients with bradycardia remain unclear. So our aim is to investigate these 3 different pacing modalities, conduction system pacing, biventricular, right ventricular, in patients who require pacing due to bradycardia. So basically, the clinical question is, are these alternative pacing modalities better than the gold standard, the right ventricular apical pacing? Our population is patients who require pacing due to bradycardia. We are comparing conduction system pacing or biventricular pacing to right ventricular pacing on different outcomes. Our hypothesis is that conduction system pacing and biventricular pacing are superior to the right ventricular pacing. And if our hypothesis is true, that means that we could directly translate these results into clinical practice, adopting the best pacing options for patients. During the meta-analysis, of course, we developed a search key, and with this search key, we found more than 12,000 articles, and we narrowed it down to 79 full texts. We have made the most comprehensive meta-analysis with more than 20 outcomes, but in the following minutes, I would like to share with you the most important ones. This figure is about the all-cause mortality in patients with bradycardia. Here we are comparing conduction system pacing to right ventricular pacing. The outcome measure is odds ratio. The null effect line is 1. Value below 1 means that the result was the outcome was less common in conduction system pacing patients. We pulled together more than 28,000 patients. The heterogeneity was high, probably because of the observational design of the studies. And as you can see, the odds ratio is 0.6, which means the all-cause mortality was reduced by, the odds of all-cause mortality was reduced by 40% in this specific patient population, meaning that, this could be a better option for these patients. And the same trend you could see when comparing biventricular pacing patients to right ventricular pacing patients, where the odds was as well reduced, here by 20%, with, which is clinically important and statistically significant as well, because we would like to find a better pacing option for these patients. The second figure is about heart failure hospitalization. That means that patients were hospitalized because of heart failure decompensation. As here as well, you can see conduction system pacing patients compared to right ventricular pacing patients. Odds ratio was put together, and as you can see, the odds was 0.4, meaning that the odds of heart failure hospitalization was reduced by 60% in this patient population, which was statistically significant as well. And the same trend you can observe in biventricular versus right ventricular pacing patients, with the odds ratio being reduced as well here, which is clinically important and statistically significant as well, because we would like to find a pacing option which could reduce heart failure hospitalization. And the third figure is about left ventricular ejection fraction. This is how we measure the function of the heart, and it is very important to observe it before and after pacemaker implantation as well. We are comparing conduction system pacing to right ventricular pacing. We are comparing mean differences, and as you can see, the pooled together mean difference was 0%, meaning that the ejection fraction was improved by 3% in the conduction system pacing patients, which was statistically significant as well. And the same trend could be observed in the biventricular pacing patients with a point estimate of 6.2%. Here being improved in biventricular pacing patients. So as a conclusion, we can say that conduction system pacing and as well as biventricular pacing is highly effective therapy. The implication for practice is that clinicians should prioritize CSP over right ventricular pacing in appropriately selected patients, although randomized control trials are further needed. The strength of the meta-analysis is that this is the most comprehensive meta-analysis, rigorous methodology, and also a big sample size. We also have some limitations, mainly due to the observational design of the studies and the moderate to high heterogeneity. So regarding the first project progress, we are currently finalizing the grade, and we also have a deadline for the manuscript, which is 20th of September. So let's see the second project, which is as well very interesting. It is investigating the incidence of atrial fibrillation after atrial flutter ablation through a systematic review and meta-analysis. Atrial flutter and atrial fibrillation are closely related arrhythmias, and both are highly associated with the risk of stroke. Radiofrequency ablation is a highly effective treatment for flutter. However, there is a remaining risk of subsequent atrial fibrillation following the ablation procedure of the flutter. So this is critically important for guiding the anticoagulation strategies. Therefore, our aim is to investigate the incidence and pattern of clinically confirmed atrial fibrillation following flutter ablation. So the clinical question is, what is the real incidence and pattern of atrial fibrillation following flutter ablation? We are investigating the population of patients who already underwent atrial flutter ablation in the context of monitoring them with loop recorders, ECGs, Holter, and we are interested in the atrial fibrillation incidence and pattern. Our hypothesis is that atrial fibrillation incidence is high in people who underwent flutter ablation. This is very important to guide anticoagulation strategies better and to reduce the risk of stroke. So in summary, we are two ongoing projects. With the first, we actually could find the best pacing option for patients who require pacing due to bradycardia. And the second project is focusing on offering more insight into the incidence and pattern of atrial fibrillation after flutter ablation. I would like to end my presentation with a quote from Ole Peterson, who was here at the Nobel event last year, and he said that the key to the success not only lies in dedication and hard work, but also in having a bit of luck and being in the right place at the right time. Thank you very much for your attention.
Until then, I'd like to ask you regarding your current practice, who decides which modality is used in which patients in the context of this quite big scientific background? Why didn't you choose the appropriate modality in the past?
Thank you very much for your question. So currently the guidelines are recommending using the gold standard, which is right ventricular apical pacing. That has been here for the last 30 years. We have the most experience with this method. Although in the 10 years ago, this conduction system pacing concept has arisen like a better option, because we are pacing directly the physiological activation of the ventricles. So this is showing very, very promising results. However, unfortunately, we have only observational studies and some randomized controlled trials with results. And we are expecting the randomized control trials, the bigger ones, to publish in 3 or 4 years. Until then, we can only just rely on these observation studies, and of course on the meta-analysis we are doing from them. But another aspect I would like to share with you, that although this is the class 1 indication, I mean the right ventricular pacing is the class 1 indication, it is also mentioned in the consensus documents that conduction system pacing could be considered in selected patients, and many centers do that, here in Budapest as well, for example, the military hospital, where high ventricular pacing is expected. And high ventricular pacing means that the ventricular dyssynchrony will be very big, so we need a better option.
Okay, thank you very much.
Thank you.
Any questions from the chairs?
Very nice talk, thank you.
Thank you.
You said that the ejection fraction increases by 3 and 6%. So I'm no cardiologist. Please convince me, how is that clinically relevant?
Yes, thank you. Very good question, and provocation as well. Basically, when we are talking about bradycardia patients without indication for cardiac resynchronization therapy, we have patients without heart failure. So we have good ejection fraction at baseline. And the right ventricular pacing method can reduce over the time the ejection fraction in 30% of the patients. And basically, we would like to preserve this ejection fraction with a better pacing option. So if our meta-analysis showed that in the case of conduction system pacing, this value will be, the ejection fraction will increase with 3%. That means that it will be preserved at least. I mean, we won't harm the patient in decreasing the ejection fraction. So therefore, we should prioritize conduction system pacing in these patients.
Okay, I accept your answer. And my other question would be, did you take a look into the alternative pacing methods, comparing them to each other, or is there any thoughts on that?
Yes, actually we wanted to do a network meta-analysis to compare directly the biventricular pacing, which is the cardiac resynchronization therapy, to the conduction system pacing. However, we could not do that because we had only few randomized controlled trials, and for network meta-analysis we need more in order to pull them together. But we tried something which is, of course, with the magic of the statisticians, which is called multi-level analysis, and we compared indirectly these two pacing methods. And here you can see that the pooled proportion, for example, of heart failure hospitalization is 30% in right ventricular pacing patients, is 10% in biventricular pacing patients, and it is the smallest in conduction system pacing, 5%. So we compared these results through a multi-level analysis, and we found that conduction system pacing is better than the biventricular pacing in this specific patient population, where the indication for pacing is bradycardia, and the patients have a baseline ejection fraction preserved or more than preserved.
Okay, thank you for your
presentation.